The Digital Research Development Network is the most recent research development network that we've set up in the ARC. It was set up in July 2021 and it sits within the person-centred complex care theme in the ARC, but of course it's a cross-ARC topic that's much broader than any one theme. So it allows us to have a central location where we can bring people together where interests align around digital healthcare with specific aim to reduce health inequalities. I'd like to introduce you to the team that lead the network. Professor Tony Marson is the network chair, supported by myself as deputy chair, and Pallavi Deshpande is providing administrative support for the network. We've had 3 meetings up until this point and we've got over 80 members attending. Our membership currently consists of core ARC staff, ARC public advisors, PhD students and a variety of member organisations. So the expertise within the membership consists of quantitative and qualitative researchers, methodologists and data scientists. We've also got representatives from both integrated care systems, the AHSN and a variety of clinical experts also. It's easy to join the network because our membership is open to all. The networks provide an opportunity for those outside of the ARC membership to get involved as well in the collaboration, so non-members are also welcome. We'd like to have more representation from non-members as well as local authorities and social care providers. So please do get in touch if you're interested in coming along and contributing to future meetings and collaborations. When we set the Digital Research Development Network up, we defined the aims and objectives with the initial members of the network. So network members put forward various suggestions and all members attending the initial network meeting voted on what they thought the overall aims of the network should be, on how success should be measured and assessed, and also on the main priority areas the network should focus on. The top 3 aims of the network are to develop ideas and projects for external grant applications, to find solutions to digital inequality, and to develop a digital healthcare strategy link with other schemes in the North West Coast and in the UK. Measures of success for the network focus around primarily the submission of external grant applications and published outputs. Longer term measures of success focus around the engagement of with organisations and network both locally and nationally, and to develop implementation studies that aim to increase access to digital healthcare. The network has undertaken a prioritisation exercise and has identified 3 priority areas for work, with number 1, to highlight and build research projects around the gaps in healthcare provision that can be addressed by digital healthcare interventions. Also to examine how digital healthcare can help or hinder social exclusion, and to examine digital technology and its impact on mental health, exploring how digital technology can facilitate mental health interventions, and also examining any mental health risks associated with the use of digital tech in healthcare. The meetings that have taken place so far have been used primarily as networking and knowledge exchange opportunities, which has provided members with the chance to showcase their research interests and their areas of expertise. Already we've seen examples of work from members that fit within the identified priority areas. So presentations and themes of work that members align with fall within, for example, the use of digital technologies for screening of health conditions, such as atrial fibrillation. Members have showcased their expertise in the development and evaluation of app-based technologies. We've seen some examples of app-based technology around mental health interventions for people with substance use, and also interventions focused on advanced patient-reported outcome measures to improve palliative care for both adults and children. We've had a series of talks around the popular topic of remote consultations. So far they've covered conditions such as epilepsy in both adults and children, rheumatology and respiratory care in paediatric settings, and more generally looking at multimorbid populations and remote consultations. Studies have examined remote consultations from a primary care, secondary care and health visiting service perspective so far. The network meetings have also been a great opportunity for our members to present to us about the different methodologies that they're experts in, especially those around developing and evaluating health innovations, a real-world validation approach is one of those examples, and we're going to hear a little bit more from Graham Smith about that later on. At the next couple of network meetings, we'll review the priority areas, and in the near future we'll form subgroup areas to work towards external grant applications focused around those priorities. But in the meantime, one of the examples I wanted to talk about was a project that's associated with the network that I'm leading on remote consultations in primary care during COVID-19. It's a project that's been discussed with the network since the first meeting and has benefited from membership engagement and collaborative input from the membership to support the qualitative analysis. It stems from the changes that have been seen in healthcare delivery since the onset of COVID, which has been a catalyst for changing how people access primary care and speeding up the adoption of remote consultation technology in primary care. It's been done obviously mainly to keep patients and healthcare staff safe, to reduce the face-to-face contact and of course adhere to social distancing measures. And we know that things have changed recently. Things are going back more and more to face-to-face consultations, but still the likelihood is that those technologies are not going to disappear, and the process for many people is that access in primary care begins with an initial e-consult, either completed online or with the help of a GP receptionist. This then generates information for the patient to either self-manage their concern, or it generates a video or a telephone consultation. If deemed clinically necessary, a face-to-face consultation will be suggested. Sometimes patients now can request a face-to-face consultation as well. So part of the study that we're conducting is to look at those changes over time. So as we know, with all of these new technologies, they existed prior to COVID, but some systems such as eConsult were not in use to the extent that they are now. Patients and healthcare professionals didn't necessarily take up the remote consultation option frequently, and the patients that did tended to be younger, in higher income groups and employed. So before COVID, research suggested that generally patients had a positive view of remote consultations, but the nature of their complaints were often minor or related to ongoing problems, and we don't really still have a full understanding of the implications of this way of accessing primary care on the population generally. So this project gives us the opportunity to ask patients and healthcare professionals their views on current remote consultation practices and find out more about their experiences in order to use them to inform future improvement programmes that are equity focused. So just to provide a little bit of background, as the number of appointments in general practice fell, the number of face-to-face appointments, the proportion that took place remotely increased. And in April 2021, remote consultations still represented 41% of all primary care consultations. That's decreased slowly to 36% in October 2021. Findings from studies conducted early on in COVID found that, the change in primary care was seen as quite successful, but there were some concerns about negotiating face-to-face appointments for those people who wanted them. So also the success was greater for those services who'd been earlier adopters of the online triage systems. And for some, these changes provided opportunities to enhance services with telehealth care. But there were also concerns about duplication of work and increased GP workload and burnout issues for healthcare professionals. The main aims and objectives of this study were really to look at how is a remote-first approach changing primary care, what the impact of this approach is on patient access to care and their views of the quality of care that they're receiving. How can this approach be used best in the future, and when's an alternative more suitable, and who is that for? So we also really want to look into the health equity issues associated with this type of healthcare service provision. We've used a mixed methods approach, which involves patient and healthcare professional online surveys. They're conducted over 3 waves, approximately 3 months apart, and a small number of qualitative interviews. Recruitment has been via GP practices in the Northwest Coast who've sent out text messages to patients with a link to participant information, online consent and the survey. And the healthcare professionals have been emailed the survey. in participating practices. In addition to that, the study is being advertised on social media and in GP practices on the screens. The study launched in November, and overall 22 GP practices sent out text messages to their patients. We also promoted the study widely on social media and in newsletters. Over 1,000 patient surveys and 65 healthcare professional surveys were completed across 45 GP practices. We kept the survey open for an additional 2 weeks due to the pressure on services as this launched during the Omicron wave. And respondents completed the free text fields in the survey with enthusiasm. So although we have collected data from the first wave survey, we've not completed analysing it just yet. To give you a flavour of the demographics of the population who've completed the survey so far, almost 70% were female, over 50% were 55 years or older. White respondents were disproportionately represented, as were those who were well educated, and almost 70% of respondents reported that they had a long-term health condition. Patients reported that recent consultations with their GP practice had been more likely to be via telephone, e-consult or face-to-face. Their preference for future consultations is for them to be face-to-face or by telephone, and their greatest preference for the frequency of remote consultations is for them to be occasionally remote. Preliminary findings from the qualitative free text sections of the survey show that patients report that remote consultations were efficient, convenient and safe. They were good for minor or transactional needs. However, people were least satisfied with the examination conducted by their clinician and expressed concerns about the accuracy of remote diagnosis and the risk of missing important health issues. Patients' main concerns also focused around the lack of patient choice and difficulties with communication when not face-to-face. Also, they reported concerns about the quality of the care that they were receiving, and they want more choice in appointment type in the future and additional improvements to the triage systems. Limitations in the study so far can be seen by the biased response, which indicates that further work's needed to identify those experiences that have been had by people who in populations that are not well represented in the survey currently. We look forward to conducting further in-depth analysis on the data that we've got from this wave of the survey and reporting them in the future. Now I'd like you to hear from one of our public advisors in the network, Dorcas Akajo, and one of our members, Graham Smith.
Hello, my name is Graham Smith and I'm a reader in mental health at Liverpool John Moores University, the Faculty of Health. I'm also the Innovation Lead at the faculty. I lead the Centre for Collaborative Innovation in Dementia, which is a living lab, and we have a team of research assistants and postdoctoral researchers. The team at Liverpool John Moores University are involved in developing a number of different solutions to people's challenges with a number of conditions, so we don't just focus on dementia. And part of that work is within the digital health space, so we work with medtech and also other solutions such as apps. A living lab is a research environment, but it's a pragmatic research environment, and it works with users and other stakeholders in the development of, in this case, digital health type solutions. It's a common name across continental Europe, but less so within the UK. At the moment, we are engaged in a project called Liverpool Health Matters, which includes moving from co-creation, which is the start of the process of developing solutions with partners, to evaluating those solutions within the real world, so through what's called a real world validation approach. The Living Lab is underpinned by a number of principles, as you can see in the diagram. The main focus is around co-creation and co-creation in a real life setting, but also working with a number of partners is really important. And being involved in the Digital Health Network assists us in being able to connect with different partners and to look at different approaches that can support citizens across Liverpool City region to live well with a number of conditions. At the moment, we're involved in, yes, dementia, but also looking at mental health as well. Co-creation is of great value to not only users involved in the process and partners, which also includes being users as well. It's a value to the system, the health and social care system, moving forward. And it can improve the lives of people living with a condition, and that includes their quality of life. What the Digital Health Network allows us to do beyond networking is also be able to look at other opportunities for us to engage with grant funding, for example. So we've been involved in a number of European funded projects, which are innovation growth type projects, and now we're involved in the National Institute of Health Research, mainly around I4I, which is the development of inventions to the real world and being implemented within health and social care.
To know everybody, the part I'm doing this afternoon is to tell you about my experience as a public advisor as a member of Digital Healthcare Network. My name is Dr. Sakeju Obiye. I was a midwife for 35 years, supporting and caring for women until they had their baby. I set up a clinic for women whose second language is English, and that clinic is still running at the Liverpool Women's. I volunteered for so many organizations, and I joined the CLAC, which is now the ARC, in 2015 as a public advisor. I'm now the co-lead for ARCA, which is Health and Care Across Life Course team. I want to just tell you that before, digital health itself refers to the usage of digital technologies to enable universal healthcare. The access improve healthcare outcomes and the quality of care, physical and emotional well-being, early diagnosis of the threatening conditions and diseases, management of chronic conditions outside of traditional healthcare setting, empower consumers and patients to make better informed decisions about their own health, and personal-centered healthcare to the public. My experience, before I joined the network, I didn't have much knowledge about digital healthcare, but about a year ago, I was involved in monitoring my own blood pressure at home with my oxygen level, and I had telephone support. So if I'm worried, I could always ring them. That's the experience I had. As a public advisor, I wanted to join the network because I wanted to know more about the use of technologies for healthcare. I want to understand more about the network and what they do. And I want to have insight into the research of digital healthcare. I want to be part of it, shaping the future of care, of the way the care is through research and supporting the network. Looking at the languages that they're using in research, because sometimes the public and the patients, we don't understand some of the languages they use. By being part of the network, I can read the research, I can participate, I can make constructive comments as well, and ensure that the language is something patients and public will understand. I think the network has its own advantage within the making of technologies, because the researches we're doing will make us to be able to make sure that it's good for patients. And I still hope that I can still be part of the network and being able to support them. Thank you very much for listening.